So good morning, everyone. I'm Dr. Christie Brillante. I'm an assistant professor at University of Illinois. I also function as the medical director at the outpatient pulmonary clinics at the Jesse Brown VA. I have no disclosures pertinent to this talk. So I'm going to be discussing asthma and obesity. We're going to be going over a little bit over the asthma and its different phenotypes, as well as obesity and its phenotypes, which is rather interesting. The epidemiology, why is it that when the two overlap, there's actually worse outcomes? And then what happens when they overlap? And finally, what we can offer our patients. Okay, so just to begin with definitions, we know that asthma is a chronic inflammatory airway disease. The common symptoms you can see here. Wheezing, coughing, chest tightness, shortness of breath, waking up during the night, needing to use a rescue medication. I think we're familiar with all of these symptoms. And we know that asthma is not the same for everyone. Asthma can be different things to different people. And so that's what we kind of describe as the phenotype. So a phenotype strictly, in terms of definition, it's a set of observable characteristics or traits. It tells us what the disease looks like. And it reinforces the idea that not all asthma looks the same. And I think intuitively, we all know that. We have, I remember when I was a fellow, I saw this, I was like, oh my God, I thought asthma was just asthma. And then I realized, okay, you've got like the allergy type or in my head, my shortcut was that it's an allergy type or a T2 type asthma. And then you have a non-allergy type. And we can see here, there are some things that we kind of intuitively know. There we go. So we have the allergic type where you have a person who has different triggers. You've got pets, bugs, bed bugs rather, or dust mites that can trigger the asthma. Then Dr. Sharmili has discussed the exercise-induced bronchoconstriction or exercise-induced asthma. Some other kinds are the aspirin exacerbated type of asthma, where people have polyps, they've got reactive airway disease, and they have an intolerance of asthma. So these are kind of the more common ones that I think are very well, discussed in for all types of medical practitioners. And we're also very aware, unfortunately, about the smoking-related neutrophilic type of asthma. I think one that has gained recognition is the obesity-associated asthma, and unfortunately, that's not an allergic type, and so it's not generally an allergic type, so we have less, it's kind of late in the game in terms of how to manage it. It wasn't so, quote unquote, easy as to manage the allergic types, because the medications that we have tend to work better for the allergic types, and I'll go into that more. So that's talking about the different asthma phenotypes. And what I was not super aware of until recently was that there are actually different obesity phenotypes. So obesity is traditionally defined as an excess of body fat that causes risk to health, basically. So most commonly, we use the BMI or body mass index to describe it. The BMI, of course, is not perfect, but it's an easy kind of standardized measure. By convention, a lot of people use it. It's fairly easy to calculate. You've got the body weight in kilos. You divide that by the height in meters squared. And if the BMI is higher than 30, then that's classified as obese. And so that is kind of specific to the Western Hemisphere and European cultures, because in Asian cultures, they actually have a lower classification for BMI because the cutoff for excessive fat accumulation is different. So, but in the US, this is what we use. And so we know that there's a relationship, and it's a J-shaped relationship between the BMI and adverse outcomes. So this actually comes from the Global BMI mortality collaboration. So I like this study. It's a nice meta-analysis. They looked at data on mortality from around the world. So it was like East Asia, Europe, North America. So not just confined to the US. And it was restricted to people who were never smokers, because we know smoking in and of itself is going to increase your mortality, and for people without pre-existing chronic diseases. So this excludes people with diabetes, for example, people with asthma. This is just pure obesity in non-smokers. So we know on the x-axis here, you've got the average BMI, and then on the y-axis is basically the risk for morbidity. And we said, or sorry, mortality, and we said it's a J shape. So we know obviously if it's, you know, your BMI is very low, you're underweight, chances are malnourished, that's associated with a higher disease, higher risk of death. And then it, on this arm over here, once you go above, you know, really here they use 25, but at the closer you get to 30 and above 30, you have like a really high risk of death, even independent of smoking and independent of any other diseases. So that's obesity and why it's associated. And this is just the BMI. Like I said, it's not a perfect measure. There are other, you know, better measures for obesity, but this is one of them. So there's actually there are actually different phenotypes of obesity, the same way we have different phenotypes of asthma. So these are the 4 quadrants of obesity. You've got, again, you know, it's what the disease looks like, and not all obesity looks the same. So on the horizontal axis here, you have the BMI. Imagine that this cutoff is 30. And then over here on the vertical axis, you've got the risk of diabetes or cardiovascular disease. And what this attempts to do is to divide people into metabolically unhealthy obese versus metabolically healthy obese. And so what does it mean to be metabolically unhealthy? So we're talking about this part of the graph. So they're obese, but one is metabolically healthy, meaning although they have high adipose or fat, the inflammatory status, meaning their inflammatory biomarkers, aren't increased. Their adipose tissue function still functioning the normal way. They still have normal insulin sensitivity. And most of the fat is actually in the subcutaneous area, meaning under the skin and not in the visceral area. So you can see that here, it's mostly in the skin area versus in the abdomen, whereas the metabolically unhealthy would be the exact opposite. You have more visceral fat, meaning it's covering the organs. And you have high inflammatory status, high insulin resistance, and the fat tissues don't function the way that they're supposed to. There's also less storage capacity in the skin and subcutaneous tissue. It tends to build up in the liver, and so you can get things like fatty liver disease, and it builds up in the skeleton. So you can see the yellow dots here, and the yellow dots in the muscle, kind of in cartoon form of where the fat accumulates. So there's a dividing line between people who are, and it's the same thing too, by the way, whether you're obese or not, you also have like the skinny fat and the skinny, I guess. So you can have healthy people, or sorry, metabolically healthy people who are not obese, and metabolically unhealthy people who are not obese. So normal weight, but they have insulin resistance, they have high inflammatory markers, things like that. Okay, so what is it? Like, why is there a relationship between obesity and asthma? And part of it, there are a lot of, several hypotheses about how this works, but one of the more well-established and popular ones is that obesity, as we saw over here, when you're metabolically unhealthy, you actually have a lot of inflammation. You've got insulin resistance, the mechanical effects, and I'll get into that a little bit more. Dysynapsis, I'll get into that a little bit later, and impaired airway host defenses. All of these metabolic dysfunctions lead to diseases of the heart, the brain, renal failure. Some people develop cancer, and then also asthma. And so asthma, unfortunately, can exacerbate kind of these effects and further increase obesity. And so it's like this vicious cycle where it just, one thing makes the other thing worse, and this makes the first thing worse. So it's a terrible, like, vicious cycle. So, what are the clinical features associated with obesity? I think the classic, the prototypical patient that we think about sometimes, it's a non-atopic, meaning non-allergic type person, usually middle-aged woman who has very severe symptoms. So severe in the sense that they're all the same symptoms, meaning wheezing, coughing, short of breath, and having nocturnal symptoms, so waking up earlier than usual or waking up at night. But they're more severe when compared to lean individuals. There's also a higher risk of hospitalizations, and obviously a higher risk of corticosteroids, because we know that obviously we use corticosteroids to treat asthma flare-ups, and that is also unfortunately associated with increased appetite, increased weight gain, and elevated glucose levels. So not great. So in the United States, this is taken from data 2011 to 2014. And what it looks at is the prevalence among adults, so 20 and above, of the normal weight, the overweight, the obese, and the percent with asthma. And so you can see here that if you're obese, you actually have higher rates of, so green being obese, you have higher rates of the diagnosis of asthma. Women tend to be disproportionately affected by that diagnosis. Which also kind of makes sense because we know that women have increased contact with healthcare settings, as well as, unfortunately, the way fat is distributed in our bodies. Plus, we have the burden of pregnancy, the weight gain associated with that. That can be the reason why there's higher risk of obesity, as well as asthma in the female population. Okay, so let's go to the effect of obesity on respiratory function and symptoms. So you can see in this cartoon, I love how it's, in this figure, I love how it kind of simplifies really the complex processes involved in breathing, and which is complicated by obesity. Basically, you'll have decreased lung compliance, which means that the airways don't open up as much. You have reduced lung volumes because the lung can't open up as much because you have the weight of the chest wall, the fat on the chest wall, and sometimes large mammary glands that are compressing on the chest wall so the lungs can't expand. You actually have increased airway resistance as well. The respiratory muscles are not as strong as they need to be. And just a lot of different, what do you call this, alterations in how gas is distributed in the lungs if you have obesity. So this diagram kind of takes into account the different types of obesity phenotypes. Well, two major ones anyway. One I think that we're kind of familiar with, this is called gynoid obesity. And as you can see, the fat is more distributed to the lower portion of the body. And android obesity, this is when the fat is central, or it's more in the abdomen. This is actually associated with higher visceral fat distribution, which is associated with higher mortality. So central obesity also tends to be worse in terms of asthma control. So you've got, and it's because the breathing symptoms are worse when you have android obesity. So if you can imagine, if the fat here, or actually let me go here. So the fat in the belly pushes up, it displaces your diaphragm up. So then you have less space for your lungs. Okay, so they basically get squished. And these red dots indicate pleural pressure. So a lot of pressure from the external pressing on the lung, so it prevents it from expanding. And so if you have central obesity or android obesity versus gynoid, it's actually associated with worse shortness of breath. You have increased work of breathing, and you can have a tendency towards lower oxygen levels. Okay, so that kind of sets the stage for the terrible, terrible Venn diagram of asthma and the obese. Because you have asthma, you've got obesity, you've got shortness of breath and wheezing, and when they overlap, it's really difficult to kind of extricate them from each other. And one of the challenges of diagnosing asthma in the obese is that breathlessness is a common symptom in both, right? You've got shortness of breath in both. And several studies, I should say, have shown that there's significant misdiagnosis. There's both overdiagnosis and underdiagnosis. The problem with asthma is that in and of itself, it's difficult to diagnose. Even when you have a physician diagnosis of asthma, what they found was that in 32% of obese patients, they ended up not even having bronchial hyperresponsiveness, which is one of the characteristics of asthma. And then in the non-obese group, it was the same thing, so 29%. So, you know, that's a pretty high amount of misdiagnosis. And that could be the nature of how the studies are performed, because we also know that asthma is episodic. You know, one day you're good, next month you're bad. So it depends also when they caught it. But just to give an idea of how it can be misdiagnosed, particularly when you have a confounding variable like obesity. So let's go over what we're going to do about it, basically. So just as a quick reminder, we have the fundamentals of asthma management. I think we're all familiar with this. So we've got number one in the middle, avoid the asthma triggers. I love this diagram. I think it's perfect. Like, it says everything here. You've got the classic triggers for our patients, you know, smoke, strong odors, pollution, anger, stress, pets, exercise, pollen, bugs in the home, chemical fumes, cold air, fungal spores, dust, you know, everything's here. But people are people, and we have to live in the environment we have, right? The second part that I want to talk about is the classic stepladder treatment, which is the pharmacotherapy for asthma. Classic things, you know, you have the SABAs, you've got the ICS formoterols, ICS LABA, and then this is the last part of it is to treat the whole patient, right? And that can, you know, vary depending on time constraints, resource constraints, but as much as possible, treat the things that we know that can worsen asthma control sometimes. So that's acid reflux, obstructive sleep apnea, because patients who have untreated sleep apnea are also going to wake up at night feeling short of breath. And that can definitely decrease their asthma control test scores. Depression can be associated with worsening asthma scores, and then nasal polyposis. It's definitely a confounder. And adding to this is going to be obesity, right? I mean, if they have overlapping symptoms, that means that we have to treat that part too. So the problem with trying to treat asthma in the obese is that our medications just don't work as well as we'd like them to. With objective measures, meaning using a spirometer, there tends to be less response on a spirometer to inhaled corticosteroids and the combination of inhaled corticosteroids and LABAs. So that's real. That sucks, honestly. You already have worse symptoms, and then the medication doesn't work as well on you. So there's also, and there's a little bit out of my wheelhouse because I'm an adult. I'm an internist, so I deal only with adults, but it's been shown in some studies that children actually have higher usage of beta agonists and oral steroids. From what I remember from my training, that's not great, particularly for bone growth for kids. And we also know that budesonide is actually less effective at improving lung function, basically. And it doesn't reduce emergency room visits. or hospitalizations for kids that are overweight or obese when they're compared to kids who have normal weight. So then what can we offer for our patients? I think one of the first things that we can offer is a more accurate diagnosis. And I like this. This comes from, I forget the name of the work group, but basically what they're trying to overcome here with this diagram is to prevent the underdiagnosis and overdiagnosis of asthma. And as you can see here, it's actually a process. It's not a one-time thing like, okay, you got asthma, here's your list of medicines, bye, go back to your life. It's a process. So you have a patient who presents, this is specific, by the way, for patients with obesity, which is something that I like. So you look at patients with the respiratory symptoms. Are the symptoms typical of asthma? Definitely get a history of asthma and rule out some of the other possible confounders for asthma. If they have that, then you want to do the spirometry test. So patients should still go for pulmonary function tests. And I actually would add a critique here that would say, don't just do the spirometry test. There are other parts of the pulmonary function test that can support a diagnosis of asthma. So I would recommend getting the full report, the full test, meaning include the lung volume, so that if there's evidence of hyperinflation or air trapping, that can still support the diagnosis of asthma, even if you don't have significant bronchodilator response. So let's say that the results don't support a diagnosis of asthma. There's a recommendation to repeat the spirometry another day. So it's just like anything else in life, how you can have a good day or a bad day. Our lungs can have that too. And so, there's evidence to show that you can actually repeat the spirometry test or the pulmonary function test. Maybe give the patient a few months, treat them empirically in the meantime. And then you also have more data points in terms of seeing how they respond to treatment as well, because that's another piece of evidence basically for or against the possibility of asthma. So that goes here, like to consider a trial of treatment. Okay, so other objective tests. Let's go to this one. Okay, so this is another table that helps give us an idea of other ways for confirming the diagnosis of asthma in patients who have typical symptoms. And again, remember, obese patients will have typical symptoms are just more severe. So variability, airflow limitations, all of these things are diagnosed with the spirometry. You can also do an exercise challenge test. University of Illinois definitely does this. And although I have to say, maybe I don't think we utilize it as much as we should, but it's definitely something that's done. Maybe not all pulmonary function labs do it, however. So that's the diagnosis part. What are we going to do in terms of the treatment part? So I think number one is there's definitely utility in discussing the elephant in the room. And I will preface this by saying that every patient deserves an appropriate workup. And if a patient presents with shortness of breath, with wheezing, they 100% deserve a full evaluation. And they deserve for their breathlessness to not just be chalked up to being obese. Okay, so they deserve 100% to get evaluated for maybe exposed for their triggers, to get pulmonary function tests. But they should also be made aware that even if you do have asthma, sometimes obesity in and of itself can confound that. And so let's go ahead and treat that as well. So just bringing it up, but kind of reinforcing the idea that I'm going to treat the whole you, and but I'm bringing this up because it's playing a role in your symptoms. So I think approaching this with empathy for the patient and letting them know that they deserve 100% like the workup for asthma, but we can't ignore that weight is playing a role in their symptoms. Okay, and what we found is that even a 5% weight loss can improve asthma control. So this one study showed that this was actually published in the Annals of American Thoracic Society. So it's a really good study that showed that losing 5% of your weight will improve asthma control, and it doesn't need to be a special program. So they actually had two groups. One group received a pedometer and a weighing scale, and they were given a list of weight loss programs. So this was done at Kaiser Permanente, I think in Northern California. And then group B was given like a full 12-month lifestyle program. What they found was both groups lost weight, even if though group B honestly like had a more resource intensive 12-month lifestyle program. By bringing it to the front of mind of the patient that, you know what, check your weight, increase your physical activity, and here are some resources for you, that actually improved the asthma control in both groups. And that was done over a year. So a year is a long time, because you could probably lose weight very quickly, but to maintain it over a year, that's quite a feat. And then secondly, we want to encourage exercise. So this touches a little bit on what Dr. Nyanhais was talking about. And this was a randomized controlled trial looking at asthma control in obese adults. What they found was weight loss plus exercise versus weight loss plus sham. So I was wondering, how do you do sham exercise? People know that they're exercising. So it's breathing and stretching exercises. So things like light yoga and just breathe, like hatha yoga breathing exercises, versus actually like aerobic, increasing your heart rate and doing resistance weight exercises. If you do weight loss plus exercise, that actually improves your asthma scores. And it actually also further improves the lung function. So when they do objective testing, meaning on the spirometer, and improves anti-inflammatory markers. So like when they check, for example, the IL-6 levels, which is an inflammatory marker, those actually decrease. And that could be because we know that aerobic and resistance exercises will actually improve your anti-inflammatory profile as well. So aside from encouraging weight loss through exercise, there are other specific interventions, because sometimes our patients will fall under the metabolically unhealthy obese group, who will have asthma as a component of the metabolically unhealthy profile. And so there's actually some interesting studies that looked at specific interventions. So for example, for patients with concurrent asthma and diabetes, this was a retrospective study actually from a while, this is from 2016, that looked at individuals who had asthma plus diabetes. And what they found was that those who were on metformin actually had a lower risk of asthma-related hospitalization and a lower risk of asthma exacerbation. And so just looking at, just a quick reminder, you know, I'm not an endocrinologist, I'm not even a primary care physician anymore. It's been a while since I've had to do that, but just a quick reminder about how metformin works. It's going to decrease hepatic glucose production, decrease intestinal absorption of glucose, and it's going to improve insulin sensitivity. And we know, kind of interestingly, as an aside, metformin is one of those medications that's kind of overall been associated with some improvements in terms of metabolic profile. There's some studies that have suggested that metformin is actually associated with prolonged life or decreased mortality, and even when controlled for everything else. So that's interesting actually. So maybe some of the anti-inflammatory effects of metformin could be contributing to that, independent of the weight loss that can be associated with metformin. The next drug is very popular. It's very much in the news now. These are the GLP-1R agonists. Is there a way to pull up to do, to increase the, not to increase, I was, for people to raise their hands if you've heard about this medication. The Wegovy is one of the brand names, very popular lately. It's been, yes. So Wegovy is one of the brand names. Just as a reminder, here's the mechanism of action. It actually will increase glucose-dependent insulin secretion. It decreases inappropriate glucagon secretion. It slows gastric emptying. And more importantly, and this is why a lot of people, particularly in social media, like it, is because it acts in the areas of the brain that regulate appetite and caloric intake. So it basically makes you feel full. And so therefore decreases the appetite. Okay, so I was actually really curious about whether or not there's been any data about using this for in asthma specifically, and I was really only able to find one that was large and kind of well done. It's just a retrospective review of electronic health records, though, and they looked at patients with diabetes and asthma who are newly started on these medications within an academic health center, and look at the time, like January 2000 to March 2018. So that's like a pretty big population. What they looked at was the rate of asthma exacerbations, as well as the encounters or the either emergency room visits, hospitalizations, or clinic visits for any asthma symptoms. So like wheezing, shortness of breath, cough. What they found was at 6 months, the asthma exacerbation counts were lower in patients who had been started on GLP-1R agonists versus SGL2 inhibitors. So these are other medications that can also used in asthma. In diabetes, that can actually also decrease your appetite. So the GLP-1R, for some reason, seems to have like some mechanism that can decrease asthma exacerbation. So I think this study, it's limited by the fact that it's a retrospective cohort, just looking at people's charts, but it's definitely like hypothesis producing, and is, a really interesting, I think, future direction to see if it's associated with metabolic dysfunction. And I think one of the ways that this could be expounded would be we have people who are not necessarily obese, who might just be overweight, who get put on some of these medications, who have asthma, and we can see if there's a decrease in their asthma flare-ups compared to people who are obese. But anyway, I think again, this is more of a hypothesis producing study. Really, really interesting though. And then one of my questions really was whether or not biologics decreased biologics rather in people who have obesity was actually effective. And I was, after a PubMed search, I was surprised that I was really only able to find abstracts that looked at this. And if you look at this study, the N is 12. Like that's not a great number of participants in a study. So these are postmenopausal women. Half of them had a BMI less than 25, and then the other half had BMIs that were on average classified them in obese of 34.9. All of them were on step 5 therapy already, and they received either Mepo, Dupi, or Sluzumab. And the data were compared before therapy and after 3 months. And what they looked at were the ACQ scores and the rescue inhaler use. And in this study, this was done in Europe. What they realized was that after 3 months of therapy, the Sabadaily usage for the non-obese group went to 0, and then for the obese group, it went from 6 to 4. And there was no difference, and I thought this was interesting. There was no difference in FEV1, FVC, or the ratio before or after the treatment. And I found it interesting that the conclusion in this study was that what they say is that obese asthma is more resistant to MAB therapy. I don't know. I feel like this deserves a little bit more study than that. Definitely deserves as a topic more than 12 people. For me, I think that this is, anecdotally, I've seen that that patients who are started on biologics, if they have obesity as a comorbidity, they do have a significant improvement. It may have to do with the different patient population too, because again, this was in Europe, this was done in Russia. So that's a very different population than what we treat here at University of Illinois. So yeah, that's an interesting future direction. So let's move from drugs to lifestyle, or actually specifically diet, because we know that losing weight helps. You know, a big part of losing weight is actually more diet based as opposed to exercise based, because it's really hard to outrun a burger, right? You have to jog for an hour on a treadmill to burn like 300 calories, and 300 calories is basically one burger without a lot of cheese. So it's very, very difficult to outrun a burger. And so sometimes focusing on a diet is going to be one way to modify someone's weight. And this one looks, a study that I'm going to discuss looks specifically at the Mediterranean diet. And I know that, you know, it became a fad several years ago. So let me just like review what it actually means. It's actually a model for healthy eating. It's a cultural model for healthy eating. So it's associated with lower mortality and morbidity by chronic diseases in Mediterranean populations. So it's characterized by higher intake of vegetables, of legumes, fruits, whole grains, unsaturated fatty acids, and low intake of meat and meat products. It contains a lot of fish, dairy products, and ethanol or alcohol in moderate amounts. And I like how the base of the pyramid, look at that. So it's really it's a cultural model, right? It's being physically active and treating meals as an event. So enjoying meals with other people. So having a shared component of that. And then here, the other bases, so this is like the foundation, but the base of the pyramid is going to be vegetables, fruits, whole grains, twice a week of fish and seafood, once a week maybe of eggs, cheese, yogurt, and poultry, and then less often meats and sweets. And you can still have wine in moderation, and then water daily. So there's no soda here. And one issue I get into with my patients that I talk about weight loss is juices don't count. Like juices do not go here. You have to eat the fruit whole. Because if you think about it, you're starting to begin the refining process if you juice a fruit. Part of the reason that the whole fruit is better is because you're taking in the fiber as well. And so you're slowing down the absorption of the sugar, whereas if you're just drinking the straight juice, you've taken out that part of work that your gut has to do. All right, so specifically looking at the Mediterranean diet, I thought this was an interesting study. They looked at 174 patients who were older than 16. Of course, you know, they excluded people who have diabetes, they excluded people who were pregnant. And interestingly, it was controlled for physical activity, for the BMI, and for the caloric intake. So if you're eating, you know, 3,000 to 4,000 calories of burgers and fries every day, and you converted that to 3,000 to 4,000 calories of a Mediterranean diet, meaning focusing on fruits and vegetables, with limited sweet and meat intake, there's actually a 78% reduction in having non-controlled asthma. So this was regardless of sex, so whether you're male or female, no matter what your age is, no matter what your education level is, regardless of what inhaled corticosteroid you are on, and regardless of the caloric intake. So what they found was that increasing fresh fruit actually decreased the likelihood of non-controlled asthma, but unfortunately, high intake of alcohol is associated with non-controlled asthma. So Mediterranean diet is not carte blanche to, you know, you just drink every day, even if it's a good red wine. Okay, so the last specific intervention I'm going to talk about is bariatric surgery. This becomes an option really, you know, for patients who have not just obesity, but who have significant comorbidity. So meaning that we may not necessarily have time to wait for the more traditional ways of weight loss because they're already on that really high part of the mortality curve. And they've got the other diseases, meaning like diabetes or sleep apnea that we know is associated with worse outcomes. And so we want them to kind of, more rapidly just, drop that weight. And so two major studies that look specifically at bariatric surgery and asthma control has shown that there's a significant reduction in asthma exacerbations in 2 years after the bariatric surgery versus 2 years before bariatric surgery. And so I think that one of the limitations here, of course, is just a retrospective study, not randomized. It would be very difficult to do a randomized control study on somebody who gets bariatric surgery and somebody who gets a sham bariatric surgery. That would be unethical. And we don't know how the asthma is diagnosed in the population. So it just, take it with a grain of salt. But in a larger study where it was a systematic review, what they found was that bariatric surgery offered greater weight loss. So people lost 22 to 36% of their weight. Remember, we said that losing just 5% of your weight can actually improve your asthma symptoms versus people who went with a non-surgical option. So they lost a maximum of 14.2%. There was actually also increase in medication use in the non-surgical group. And for the bariatric surgery group, there was decreased airway responsiveness, decreased hospitalization or healthcare usage, and improved lung function. So for the bariatric group. So this is a systematic review for that, but they also noticed, and what was interesting was that the changes in inflammatory markers are variable. So just something I want to bring to the group is that we know bariatric surgery isn't, to get to it, well, in University of Illinois, it's about a year-long process, right? So you get referred by a physician. Sometimes I refer patients myself, and then they get seen in the bariatric clinic. They're evaluated by nutritionists, by social worker, by physicians, and the nurses. They get started on a lifestyle regimen. They do have to lose weight first before they can get the surgery. They have to pass a psych eval. They have to be seen and evaluated by pulmonary, by cardio, by sleep medicine. And about, at the end of the year, if they're able to pass all those, then they can qualify to get the surgery. But it doesn't end there because you have to maintain it like anything else in life, right? So it's not like people can just get bariatric surgery and that's it. You have to maintain the lifestyle. You have to maintain portion control. And so sometimes that's the issue with bariatric surgeries. People think that it's a shortcut to losing weight. It's really not, because you can definitely fail bariatric surgery and you're limiting your options at that time. I knew a guy in med school who actually, he had bariatric surgery before he started first year. By our fourth year, he was back to where he was before. So it's definitely possible to fail it significantly in a span of 4 years. So yeah, it's not a magic. Nothing is magic, unfortunately, when it comes to weight loss. So I would set patient expectations to be realistic and to let them know that they have to maintain the process. So that is the end of my talk. I'd like to acknowledge Dr. Neinheis for pointing me in the right direction, Dr. Papalardo for inviting me to speak, and of course everybody here for taking the time out to listen. Thank you.
Thank you so much, Dr. Brillante. This is fantastic, and it's so hard to think about obesity as an inflammatory disease. How that influences everything. And since asthma also is inflammation, it's like, of course, it makes more sense that both will lead to inflammation. And this is a relatively newer concept that's getting out there to people that says obesity actually causes inflammation too. And then you talk about these dietary interventions, and it's kind of like, when you have asthma with atopic disease, I mean, people have food allergy, what do? How do you reconcile this? You know, when you know fish is good, but you're allergic to them, it's really hard. It's so hard. I'd like to open this up to questions for anyone to talk about some of the things that Dr. Brillante talked about, or any questions you would have about obesity or physical anything at this point before we go on to some of the nutritional ways in more details that can help our asthma.
Just to piggyback off of what you mentioned with the like fish and allergies and things, actually one of the interesting things that Mediterranean diet, the study found was, and I didn't put it in because there's a lot more to, didn't necessarily have to be in here, but what they found is that, yeah, higher consumption of certain tree nuts, and because the Mediterranean diet is high in nuts, right, as a source of protein, and higher consumption of some of the dairy products, is actually associated with worsening atopic symptoms. So it does have its limitations. And so again, though, it's the concept of it. It's not like a checkbook you have to follow, or a checklist, I should say. It's more of a concept of, you know, increasing fruits and vegetables. You know, it was never associated with worse asthma control, was increasing with fruits and vegetables. So there's always that to fall back on.
Yeah, and I think like somebody published, and I got something about like 5 vegetables and fruits a day, like, you know, a total of 5 a day, like reduces inflammation. I was like, okay, I can put my head around that one. That one's easy. And of course, they want you to have a little bit more vegetables in the fruit because the fruit's a little bit easier, those quick sugars and such. But I don't know. But you have a question. There's another question, I think.
I didn't have a question, but I just wanted to make a comment too, kind of more of a plug. Is so as you hear Christie, or Dr. Brillante, as you have here the Mediterranean diet, there is another, you know, very similar diet called the DASH diet, which is the diet for hypertension, and, you know, has been really studied well on hypertension and kidney disease. And one of my colleagues, Dr. June Ma, did a pilot study looking at the DASH diet in asthma, and showed some preliminary effects. And right now we're doing a larger study that is being conducted at UI Health. So if any, you know, if this sparks any interest, and anyone is interested, like, oh, you know, want to know more about diet and asthma studies, there's one that's ongoing right here in Chicago. So.
Isn't it called like Aloha or something?
It is
like
called
that?
Aloha.
It's like a lot easier to remember. The Aloha study. Hello, you know.
Yeah, and that diet is the DASH diet is very similar to the Mediterranean diet, with the exception they don't necessarily say you should avoid alcohol, but they don't necessarily promote it, that I think, as much as the Mediterranean diet. So
yeah, Mediterraneans don't like the idea of wine being taken away from them. You know, that's being one of them, I can say that. You know, I think, thank you so much for giving a little bit of information about the Aloha study, and Dr. June Ma, she's fantastic. And it really will help us understand, and even in major clinical trials that are going on for asthma, looking at dietary interventions, how can we change what we eat to be able to support our health and do things that we can actually control. Sometimes we can't control. We can't control our genetics. We can't control the trauma that has happened to us, but we can control how we move and what we put into our mouths to some extent. And so that's what we're going to go to next.